So today I'll talk about neuroendocrine tumors of the lung and a uncommon condition called dip neck, and we'll talk all about that. So, okay, so the pulmonary neuroendocrine tumors are really represent a diverse group of malignancies, and we'll go through just what this means, but they're grouped into essentially two broad categories. So the pulmonary carcinoid tumors and then the neuroendocrine carcinomas. Risk factors can vary. Sometimes they're in the higher grade tumors. We think about smoking as being a risk factor. Sometimes there's a genetic syndrome that can predispose you to this. Many times there are no risk factors at all, and we'll talk about how some of these things are discovered. They're uncommon. In the neuroendocrine space, they represent about a quarter of all neuroendocrine tumors. Okay, so a big portion of your neuroendocrine tumors start out in the lungs, but in the lung cancer world, they only represent about 2% of all lung cancers. So we break them into 4 different categories: the typical and atypical carcinoids, and then the large cell and small cell lung cancers. So I put the cigarettes by there to remind you that these are smoking-related illnesses. So symptoms. So obviously some of these can be very nonspecific, and I've got lots of patients who come in and they've had recurrent pneumonias for, gosh, yeah, I had a pneumonia, 5 years ago, and I get pneumonia a couple times a year, or bronchitis, or cough, wheeze, all of these things that can happen. Rarely there's a hormonal syndrome that can go along with this, including carcinoid syndrome, but many times there's no symptoms at all, and my patients come to me after having a chest x-ray in anticipation of their knee replacement, and lo and behold, there's a tumor in their chest. So that is a pretty common presentation. So how this gets worked up, we talk about imaging. So this is a CT and a subsequent dotatate PET. So contrasted CT of the chest and abdomen. If we think there's disease within the liver, the MRI is usually the best test, and then the functional imaging. Octria scans, nobody should be getting an Octria scan anymore. Okay, so the newer technology, the dotatate PET CTs are so much better, give us so much clearer pictures, pick up so much more, give us a true representation of the disease. So if your doc offers you an Octria scan, kindly suggest, can I go get a dotatate PET? And you may have to drive for it, but nowadays it's becoming a lot more location friendly. So what do we do to work this up? So obviously everything starts with a biopsy, and there's different ways to do it. So up here, this is something called a bronchoscopy or an endobronchial ultrasound, where a camera is inserted into the trachea, and they can navigate down and visualize the tumor and take a biopsy there. Sometimes we do a CT guided biopsy where this is actually an image where a needle goes through the chest into the tumor. A thoracentesis is usually reserved for patients who have fluid within the lung, and we can sample that fluid. And then sometimes we do an actual open biopsy or a surgical biopsy to get this. So this is just a cartoon of that. So this is the most recent classification for the lung neuroendocrine tumors. And again, they're different than the GI tumors. So this starts at least aggressive to most aggressive. So again, the typical and atypical carcinomas. What we look for is this. So mitoses. So this is your dividing cells. If you think back to your high school biology classes, when the chromosomes come together, this is something that we call mitoses. So the pathologist will actually look at this and count how many mitoses there are, and then necrosis as well. So on your pathology reports, we always look for these things. Many times I'll get a report and it says neuroendocrine tumor. Well, I don't know what to do with that. So I have a discussion with my pathologist and say we need to do a little bit better. And sometimes they're happy about that and sometimes not. But so we all think about staging. Staging in the lungs is this is a very simplified system here, but essentially stage 1, you have a single tumor. Stage 2, you have tumor that has spread to the first set of lymph nodes. Stage 3, this is maybe more than one tumor in the same lobe or spread to the second order of lymph nodes. And then obviously stage 4 is anything that is spread outside of the chest. And that does help guide our treatment. But the treatment is, it really does take a team. And we, at Vanderbilt, we have, I go to 2 different tumor boards. I go to my thoracic tumor board and I go to my neuroendocrine tumor board. And there's a lot of overlap between the two. And so you really need to choose that right treatment at the right time. And this is my team, this is your team for your lung neuroendocrine tumors. So it's not just myself, it's not just I'm a medical oncologist, but obviously my surgeons and pulmonary docs, nuclear medicine, cardiology, and so on and so forth. We all meet, we're all very in tune, and even outside of tumor board, we're always discussing next steps in care. So it is really important to be part of that multidisciplinary team. This is the same diagnosis on a patient, okay? So here's a CT, here's a subsequent PET. This is a different patient, subsequent PET. So the same diagnosis, but the treatments are going to be very, very different here. So this person went to surgery and this person did not. You can see right here the presence of a bone metastasis. So factors to consider when we're thinking about treatment. So we look at stage, we look at symptoms. Dr. Alt Anderson talked about the somatostatin receptors. That really plays into our, what we're able to use. Are we going to use a somatostatin analog, or can we use PRRT with patients? How much burden is there? Can we safely observe somebody? The comorbidities, obviously, in the lung space. If we're taking out pieces of lung, we want to make sure patients are going to be able to breathe after that surgery. So if they come in with underlying lung disease, that can sometimes be a problem. And obviously, patient preference. So the treatment for early stage disease is to remove it. So again, these are uncommon cancers. So we generally follow the guidelines for non-small cell lung cancer and consider a lobectomy is a gold standard. But certainly we're finding out that maybe we can get away with some more lung-sparing surgery. There's a role for targeted radiotherapy, something called SBRT, and then adjuvant treatment or treatment after is somewhat controversial, and we'll discuss that shortly. So these are the types of lung cancer resections. So a wedge resection where it's just it. We wedge out that tumor. We don't like to do that. It's not really a cancer operation. This is more of these three are more cancer operations. So this is that lung sparing procedure called a segmentectomy. Here is your traditional lobectomy where they take the entire lobe. And we try to avoid this if we can, but sometimes not. So this is something called a pneumonectomy where they take the entire lung. This tumor is very proximal. So the whole point of doing any cancer operation like this is to get everything. So if you can't get everything, you may not want to do the operation. So, all right. So adjuvant therapy or surgery after. So in my non-small cell lung cancer patients, stage 2 and higher, they're getting adjuvant treatment. So they're getting chemotherapy after their surgery. In the typical and atypical carcinoid tumors, even with that stage, we don't have really good data to support the use of it. In fact, there's some series that adjuvant treatment is actually detrimental. So it may be tempting to give it, and I see lots of patients who've had this, but there's not really good data to support it. These are the guidelines from from NCCN and ESMO and ENETS, and so your stage 3 atypicals, you've got many guidelines that say may be considered with positive lymph nodes, may be considered. We came out a few years back, we met as a group, and we went through all of this data, and we said there's no really good evidence to support this. So we said surgery without adjuvant therapy. So what are the non-surgical options? So patients, this is not an early stage disease, so advanced disease. So we can observe, and sometimes, I'll have patients come in and there's a typical carcinoid tumor and they've got multiple pulmonary nodules. But I look back at a scan that they had for another reason 5 years ago, and it's those same pulmonary nodules and they haven't done anything. Maybe that's the person I'm going to be observing. So the somatostatin analogues, you'll hear more about liver-directed therapy, radionuclide therapy. You'll hear more about today. There's a role for chemotherapy, maybe immunotherapy. And then Dr. Alf Anderson already talked to you about the targeted therapy. And then we always try to remember our clinical trials, because that is how we advance our field and how we learn about the next treatments. So the somatostatin analogues you've heard about, we've got 2 of them in the United States, octreotide LAR and lanreotide. So this is the octreotide, this is the lanreotide, and you can see an improvement in the progression-free survival. So stopping the tumor growth, but I would caution, this is in the midgut population, and then this is in the GEP-NET population, okay? Well, what do we have in lung? Well, and I remember doing a talk like this a few years ago, and I put up the same slide. This was a trial called SPINET, where they took patients with lung neuroendocrine tumors and randomized them to either lanreotide or placebo. But the issue was it got stopped early. They couldn't find enough patients with lung neuroendocrine tumors who hadn't already been on somatostatin analog. So we never thought we would get this data. But this was actually just presented at our national meeting last year. We're still waiting on the publication to come out. So 77 patients enrolled, and this went on, I think, for about 5 years, and they only got 77 patients worldwide. And so what they found here was that so most of them were typical carcinoid. What they found here is a overall progression-free survival of about 16 months. So that's very good. But it turns out in the typical population, your progression-free survival was actually almost 22 months. So maybe there's a role for lanreotide. We're waiting for the publication. But I think it's certainly a reasonable option to consider, especially if you have those somatostatin receptors. So we talked about this already. We're not talking about, these drugs are not meant to help shrink tumors. When we talk about overall response rates, they're low, but they're certainly useful. But what about other options? What do we do after somebody progresses on a somatostatin analog? Well, Dr. Alf Anderson talked about this already. This is really the only FDA-indicated therapy for lung nets. So this is everolimus or Afinitor. So this showed a 52% reduction in the risk of progression or death compared to placebo. So this is sort of our go-to. This is, when we look at all our guidelines, this is sometimes, this is what we would pick. But there's also PRRT. Okay, so this is also a very good option. So this was, and I'm sure you'll hear more about this. This was the NETTER-1 study that looked at patients with the midgut neuroendocrine tumors and randomized them to either lutetium dotatate or high-dose octreotide LAR with their primary endpoint of progression-free survival. And it turns out that the PRRT was way superior to the somatostatin analog. But again, I'll caution, this was done in the midgut population. So again, the lung nets get left behind. But we're working on that. So But there's a lot of data for PRRT in lung nets, albeit most of it retrospective. So, in some large studies where, so over 100 patients here, so over 400 patients here. So you know, there's more and more data coming. I use PRRT all the time in patients with lung nets. So even though it doesn't have that FDA indication, it's on all of the guidelines and we can get it. So where does that fall into, what do we do first? We've got an FDA indicated drug called everolimus, or do we do PRRT? Well, this study is going to help answer that. So this is, this study just opened. They're looking at neuroendocrine tumors of the lung, with evidence of progression. You need to have somatostatin receptors. They get randomized to either PRRT or everolimus. If they progress on this, then they can go on to get PRRT. So this will help answer that sequencing question. Which one do I do first? So other options for lung, chemotherapy. I think it's a misconception that chemotherapy doesn't work in neuroendocrine tumors. I use it all the time. So capecitabine and temozolomide, or a regimen called CAPTEM. So this has been shown in pancreatic neuroendocrine tumors to be very effective, but I'd argue it can be very effective in patients with lung neuroendocrine tumors. This was a study from Moffitt that looked at their lung population. Again, this is a small study, so only 20 patients. Most of them were typical with low KIs, but most of them had a lot of treatment before going on CAPTEM. The response rate was about 30%. The biggest thing to take home here was the disease control rate was 85%. So they were able to stop the tumor growth, and the progression-free survival was over a year. So this does have a role. This one is not yet out. Dr. Alf Dannerson, again, he alluded to this. So surufatinib is a multi-kinase inhibitor, so inhibits some of the blood vessel formation and has other roles. But this was a study in the Chinese population that looked at patients that they actually did two. They did a pancreas trial and then they did an extra pancreas trial. So randomized them to either surufatinib, which is a pill, versus a placebo. He ended up actually stopping this trial early because they found it was effective. I would say there was a small population of lung. Only 9% of that entire population was lung. So they had 12 patients. So even though it's small, I think I'm glad they included it. So this was the progression-free survival, so 9 months versus almost 4 months. So this is with the FDA right now. We're expecting a decision later this week. So we'll, stay tuned for that. So maybe, and if it's approved, this just gives us another tool that we didn't have last week. So again, these are the responses. It's not something that, again, we're not going to shrink tumors. About 10% of tumors will shrink with this. Okay, so let me shift gears in the last few minutes and talk about a condition called DIPNEC, or it stands for diffuse idiopathic pulmonary neuroendocrine cell hyperplasia. Say that 10 times fast. So this is a rare disease. Okay, we talk about all these rare diseases here. This is rare. In fact, the largest series of patients published included 59 patients, and this is actually out of Mayo, and it took them 19 years to get 59 patients. So again, it's very rare. So diffuse proliferation of the neuroendocrine cells, limited to the basement membrane when you look at it underneath the microscope. So it tends to affect women in the 5th to 6th decade. We think it's pre-neoplastic, so this is something that can develop into the carcinoid tumor. A lot of times we see it with with carcinoid tumors. So we take out a carcinoid tumor and look at the surrounding lung, and it's involved with dipnec. So this is a relatively recent entity. So this was the first paper. This was actually published in the New England Journal in 1992, where they described this condition. So it's, this isn't something where we have decades and decades of experience with. So this, we're learning more and more about this. In fact, if you look through the medical literature, so this is a site called PubMed. So when we, go and look up the medical literature and we say, all right, what is dipnec and how do I treat it? We go to PubMed and type in diffuse, we type in dipnec, and we come up with 149 results, okay? But if I want to learn how to treat breast cancer, there's almost 500,000 results there. So it truly is rare. So what exactly do patients present with? So they can be nonspecific symptoms. So cough is the biggest thing, shortness of breath, and it can go undiagnosed for years, and often it gets labeled as patients get labeled as having asthma or COPD. Sometimes there's some characteristic findings on the chest x-ray, but we diagnose it with a biopsy. So that is, and we'll talk more about that. So I won't go into this. This is pulmonary function testing. So again, this can be often confused with other entities, but it's really, if you look at this, it's very of a mixed picture, and they can present really with any of those. So this is a CT of a patient with dipnec. I'm not sure if this will. Oh. Can we play that? So this is a video. So there's click down here. So this very characteristic findings. So there's multiple pulmonary nodules, but you look at this pattern of it. This is something called Mosaic Attenuation. And it's just, this is a very classic picture for dipnec. And so when we see something like this, our ears perk up and we say, wow, this is probably what's going on. This is another CT of one of my patients. So you can see this is a carcinoid tumor. Here's another nodule here, but again, I guess it's hard to see with this, but there you can see this mosaic attenuation on this. Here's another patient of mine, young woman, unilateral dipnec, so just the one side, and she had dozens of these nodules within this lung, but nothing on this side. And then looking back, she had a CT scan done many years back. Very similar finding. So again, this is that slowly progressive disease. So this is a study that showed that the median duration illness before diagnosis was almost 9 years. So again, it's somewhat of an under-recognized phenomenon, and it's probably more common than what we think it is. Again, this is that case series from Mayo. We can thank Dr. Helft Anderson and colleagues for this one. So 59 patients, the majority of them female, majority of them were symptomatic with cough or shortness of breath. Again, they'd gone through a whole host of treatments already, so the inhalers and oral steroids, but they showed that almost 18% actually had some progression over that time period to a lung neuroendocrine tumor. This was another recently published study where actually they looked at that pure dipnec, and then they also looked at something called secondary neuroendocrine cell hyperplasia. So sometimes this can happen for other reasons. So but 33 patients with pure dipnec, and you can see some of these symptoms, so cough and shortness of breath. Sometimes they're asymptomatic, and so again, I get the patients that come in without much in the way of symptoms, and I don't necessarily need to do anything other than follow them. So when it does come time for treatment, what do we do? So Dr. Chauhan and I had published this many years ago. They looked at patients with dipnec and who were on somatostatin analogues, and it turns out that all of them had a degree of symptom improvement. So this was a larger study that looked at 42 patients on somatostatin analogues, and it was a mix. So it was both octreotide and lanreotide. The majority of them had some sort of improvement. But not everybody. So about a quarter of them had no improvement. And then when we look at PFTs, again, this is something we can measure objectively. It's one thing to ask a patient to say, are you feeling better? Are you still having cough? And I've had patients that say, yeah, I'm still coughing. I don't have, I'm getting this shot every month and I'm still coughing. And I say, all right, well, come off the shot. It's not going to work for you. And then they come off and say, well, my cough got way worse. So, sometimes it's a slow improvement or gradual improvement. So, all right. So I'll stop here and I'll just say, the lung nets are pretty uncommon, as we talked about, and really require this multidisciplinary approach. Do you go to the thoracic folks? Do you go to the net folks? We're trying to combine these specialties. So surgery, always remember that. That's your first line option for early stage disease. And even though there's only one FDA indicated therapy for lung nets, there is a whole host of therapies that we could consider with this. So keep that in mind. In dip neck, again, we're trying to learn more and more about this. So stay tuned for that in the coming years. I'm hopeful this will become more recognized and we'll get some more treatment options. So thank you so much.